Hey, good morning, and welcome to the UroPatient podcast. I'm your host, Vic Sidis. We meet every Saturday at 10:30 a.m. Central Time. And if you're watching us live, we're on YouTube and Facebook Live every week. And you can always watch our on demand by going to our UroPatient.com website, where you'll find all of our past episodes. Also, the best place to go to get any of our handouts, we've got a bunch of them, so go and check those out. Every program I put out, I have a handout with valuable information for you guys. So what if you've had a vasectomy and now things have changed and you decided you want to have children again? Are there any options out there? Well, I decided to ask a good friend of mine, Dr. Landon Trust, who does quite a bit of this work, to talk to you guys about some options. Go ahead, take it away, Dr. Trust.
I just wanted to start off with a couple basic statistics on reversals in general. So when you look at vasectomies, they're very common. So in the United States alone, there's estimated to be over 500,000. Some put it 580,000, some even more per year. So, relatively very large number of vasectomies performed. And interestingly, about 20% of men regret it at some point. And you look at how many consider a reversal, it ends up being around that same number, anywhere between 18 and 25% or so. If you look at why do people regret a vasectomy? And it typically is if they're in an unstable relationship, meaning kind of an on again, off again, or just no relationship. If they're under 30 years old at the time of the vasectomy, if they've never had kids or only have very young kids, if they're doing the vasectomy because of complications of pregnancy, so, some issue where they say, oh, you shouldn't get pregnant again, something like that. Or if they were going through a financial crisis at the time of the vasectomy and life was just hectic and crazy and they got the vasectomy, all of those are leading predictors of someone who's going to potentially regret it. Now, despite that, even though 20% of men consider a reversal, only 2 to 5% will ever actually seek a reversal. And so that ends up equating to roughly 20,000 reversals are done per year. And when you look at why so many people consider it, but then only a small percentage do it, a lot of times it's because they'll go see their physician. Their physician says, oh, you can't do a reversal, it's permanent, or the success rates are too low, or you just don't even know that it can be reversed at all. So there's a big discrepancy between the potential versus how many are actually seeking them out. Well, I wanted to give some background here because it's important to know the difference between IVF or in vitro fertilization and a vasectomy reversal. So post-vasectomy, you really only have two options that you can reasonably consider to try to get pregnant. One of them is a reversal, and that's just an illustration that we had commissioned when I was during my time at Mayo. And then on the right is a dish where they're getting ready to do, in this case, probably ICSI, but you're doing in vitro fertilization there. But on the male side, you still have to get sperm out somehow because it's blocked because of the vasectomy. And that's where you get all these, 4-letter, acronyms for it. So you've got PESA, which is a percutaneous epididymal sperm aspiration. And you can see in the picture on the left there, you basically just, grab the scrotum, you take a needle, usually you'll use one a little bit bigger than this one, but you take a needle, you puncture the epididymis a couple times, and it's all based off of feel typically, and then you just suction out everything you get. And that usually includes tissue, tubules, blood, sperm, everything. You have TESA, which is this testicular sperm extraction, and that can either be done through a biopsy gun that they're showing here, where same concept, you basically just put it into the testicle as opposed to the epididymis. And this gives you seminiferous tubules with sperm as well. Now, both of these techniques are ones that aren't terribly difficult to do, and you can do them with just local numbing medicine, but they generally don't work very well. You get relatively small numbers, you get a lot of blood contamination, and the complication rates with these, believe it or not, are actually higher than some of the other ones I'll show in a second. And it's just because you're kind of blindly passing needles, it bleeds into the sac, and if they have a redundant sac, it can fill up with blood, and you can have issues like that. So those are two. The ones that are probably more gold standard, I think you'd say, would be this MESA and I put TESA there, but it should be TESI. So MESA is the on this picture on the right, this one right here, which is basically you access the epididymis, and then under a microscope you'll do a little micro dissection where you find the best tubes, pop them, and then you take sperm directly. You usually get much bigger numbers that way. You have less blood contamination, and it also doesn't damage your future if you do decide to do a vasectomy reversal later. In fact, I just did a reversal yesterday on someone who had a MESA done and had completely normal sperm counts in his vas deferens, even though, previously we'd done the MESA. A TESE, this is a testicular sperm extraction. So the other one, TESA, is testicular sperm aspiration. That was the one I showed on the other slide. But TESE, you basically go in and you take a bigger chunk of tissue, ends up being maybe 2% of the testicle or something like that. And then that gives you really big numbers. You can save multiple vials and it lasts, a long time. On the right, this is a relatively newer technique compared to IVF, which is intracytoplasmic sperm injection, or ICSI. And that's where they can take one sperm. You can't really see it real well here. This is a Wikipedia picture, but likely that may be the sperm right in here. You insert this tiny, tiny, tiny needle into the egg. And here the egg is being held on by this little suction tip here. And then you deposit the sperm in the middle of it. And then you basically pull the needle back out. This is a real neat technique since it allows for very tiny numbers of sperm to be used. So this, more and more people are starting to do ICSI almost preferentially over IVF. So to do the reversal, basically first step is you need to access the area. So we do a transverse incision. There's different approaches. There's not one that's the best thing. You bring up the vas where they did the vasectomy before, so you don't necessarily make a huge incision, bring out the testicles, anything like that. And then the video is going to show that you're going to cut across the area and you're going to sample fluid from this side. This is the side going down to the testicle, and this is the side going up and out of the body. So you're going to sample the fluid from this side, and then you wait to see what it shows. And this is going to be a big determining point as to what you do. Now, if it shows, like in this case, and this is just animated sperm, they don't really, you can only go back and forth so many times with animators before, you feel too guilty, but they don't look exactly like this. But so if you see sperm, then that says, all right, I can just attach those tubes back together in what's called a vasovasostomy. Now, if you don't see sperm, like in the other one, on this side, then that means you have to do an epididymal vasostomy where you're going to attach it to the epididymis directly. So in this case, the one that didn't have sperm, you're going to have to deliver the testicle. In the case where it did have sperm, you're going to be able to just attach these tubes directly. And so that's showing kind of the two areas. So it's showing you make an incision into the epididymal sheath here, you find an epididymal tubule, and then you're just going to attach the two directly. Now these are tiny, tiny, tiny repairs. Because they're so small, they tend to fail more often than these repairs. But if you need to do an epididymal vasostomy and you don't do it, you just do a vasovasostomy, then it just won't work, or it's very, very low success rate. So you do need to be able to do these kind of attachments when you do the procedure. So here it just shows you're going to check, and then here same thing. You'll sample that, make sure there's sperm, make sure you're attaching to the correct tube, and then you'll just finish up your repair, which is just going to be 2 layers of sutures and then supporting sutures and things like that. Put everything back in, and then the procedure is done. Close it back up. So if you put them on a almost like a table, kind of a comparison here, looking at advantages of IVF versus reversal, there's no right answer. And if anyone says, oh, you need to do X or Y, in the far, far majority of cases, that's not true. Now, sometimes you really only have one option, but in most cases, both are an option, or both. Some people will just do both at the same time. So in vitro, on average, it's faster per attempt, because if it works, you could be pregnant within 2 months without too much of a problem if it's successful. You can also get pregnant on a schedule. We'll occasionally get someone who has, they may be an actor or something like that, where I can't get pregnant on these months, but I can get pregnant on these ones. In those cases, in vitro tends to be a little bit better there, because you can predict it. You can start your cycle on this day. You can say, all right, it's either going to work or it's not, but we know you're either going to be pregnant or not on this timeline. Sometimes you don't want much of a role on the male side. So the male side says, no way am I going to have any sort of procedure. Now, granted, you have to have something because you have to get sperm out, but you may not have to have a reversal, for example. And sometimes they don't want to have a reversal. Sometimes you want the vasectomy still to be intact. And so IVF gives you that option where you can just retrieve sperm, but the vasectomy is still intact. On rare occasions, I would say in vitro is required, and there's no other options because of specific female factors. And that may be cases like where you have tubal obstruction or things like that. But in general, most cases, it's not absolutely required. So things like endometriosis, PCOS, things like that, which are much more common, you can generally do either approach. One advantage of an IVF is you can do pre-implantation genetic testing. So especially if like the female partner is older, so say 43, 44, 45, and you have a higher risk of trisomies or other chromosomal abnormalities, or if one or both of you has some genetic condition where you want to see does the baby have that genetic condition, you can do that with IVF, whereas you can't with a reversal. Costs overall on the IVF side, it costs about $15,000 to $20,000 for the first cycle, and then usually about $5,000 to $8,000 for each additional cycle if you have frozen 5-day blastocysts or frozen embryos, because those are going to be less expensive to get everything ready and then to do a frozen transfer. Plus, you have the cost of the male side. You still have to get sperm out, and that'll vary anywhere between $1,000 all the way up to $12,000. On the reversal side, so in general, it's less invasive or risky on the female side. You're not needing to hyperstimulate the ovaries. You don't get any of those potential risks of the hyperstimulation type syndromes. It almost always is more cost effective. You can see some centers that'll charge up to $30,000 plus for it, but usually, if you look around, you can get it between $2,000 to $12,000. In our practice, we do all the fertility things as a charity, so we don't make any profit off of. And I mean, it's not a formal charity, but everything is set at cost, and so we tend to be on the low end of everything. But they tend to be in this $2,000 to $12,000 range. You also have the ability to have children naturally, so you're getting pregnant on your own natural ways. Some people prefer that versus others. You can also have multiple children if it's successful with a single procedure. So you can go on to have several kids in many cases for it. And then overall, and this may be a debatable topic depending on the specific center that you're comparing. But in general, if you go to a high volume center, a place that does a lot of these, your success rates are going to be higher per attempt in all settings, including advanced maternal age, except in those cases where you have to do IVF. And that's just, I think, because you can try multiple months. Whereas, once you've done one procedure, you can try for 2-3 years. Whereas with IVF, it's a single shot type outcome there. Well, Revas, this was just something we did. So I found when we would get failures, either ours or other places failures, a lot of times they had ripped apart. And so we developed a technique where, you basically put the vas together and then you give some extra reinforcing sutures. So just an animation showing, vas being put together, inner sutures are placed, the outer sutures are placed, and then it's there, and you have sperm going across is the general idea. Well, if it gets under strain, so you pull on it, just normal wear and tear post-op, you can get either some of the sutures pulling or some of the blood supply, and then you get a stenosis or a stricture that happens. And that can happen even, extra strengthening sutures in there to make it so that if this gets pulled, it's going to pull on those sutures first before it ever threatens your repair. And so it's just going to give you a lot more strength. Even if a couple tear, you're going to have plenty of strength where it's a non-issue. Now, since we published this, we've revised this so it doesn't form this big loop anymore. Instead, we have it where it's a longitudinal type thing, so it feels just like a normal repair, but then you get all the strength of the Revas type sutures. So vas reversal patency, again, it ranges in the published literature 72 to 99%. And again, that's published. So these are people who are generally relatively experts. They're in academic centers. They're relatively higher volume. So out in the community, I found this can be as low as even 30% or so. And then pregnancy rates range, and again, this is published, but it really could go all the way down to like 4%, all the way up to the 70% or so. So roughly, 2/3 the data that we were showing, here with it and here. And again, it's highly variable. So surgeon ability, you want your surgeon to be able to do epididymal vasostomies. The majority of vas reversals performed, surgeons performing these can't do epididymal vasostomies, and that means that you may end up getting the wrong surgery done at the time of the case. Volume is really important. Technique is important. The post-op protocol, prednisone versus not. And it's important to pay attention to what data are they actually excluding when they're giving you a number for success rate. Because, some centers, for example, will say, we've got really high success rates, but they'll only operate on people less than 9 years out or highly select them. Or they'll only do vasovasostomies and only quote their vasovasostomy data, for example. So,
well, I hope you enjoyed this week's show, and I hope you understand now there are some options for you. So be sure to utilize this information, and we'll see you all next week on the UroPatient podcast.